question is, can we have a comparison of Zomita and denosumab after the clinical trial ended in January 2019? And comparison on the cost, the side effects, and also bisphosphonates are recommended to stop after 24 months. If resurgence of lytic lesions occur, what is the maximum interval for use of bisphosphonate? Monthly, 3 monthly, 4 monthly, or 6 monthly? I think the conclusion after the trial is the denosumab is not inferior to Zomita. So really, they are equally effective in preventing the skeletal-related event. And at the moment, my understanding is denosumab is a lot more expensive than Zomita. The price of Zomita has come down recently. Side effect-wise, the Zomita dosage got to be modified according to the kidney functions. Denosumab, as far as I know, there's no change in dose. Correct me if my colleagues is understanding. Yeah. Fracture risk, they can all potentially lead to this atypical fracture of the long bone. And, about long-term use, yes, they can be used long-term, but I think in general they are used for 2 years in the first instance, and if the disease is still active, we carry on the treatment. Just I mentioned earlier on that the biphosphonate tend to bind to the bone matrix, and the effect can last a bit longer. And my view is that the biphosphonate can be stopped for a bit longer, whereas because the denosumab is an antibody, the effect in the body lasts for only about 6 months or so, compared to the bisphosphonate, which bind to the bone matrix. So denosumab, for this, if we need to use them, restart using them again more often. For resurgence of the lytic lesions that occur, that would mean that the myeloma is active again. We will still carry on using, for my practice, I will carry on the treatment, either Zomita or palmitoronate, while patients on chemotherapy every monthly, according to the schedule of the chemotherapy. But again, it won't be more than 2 years.
I think the only thing to add, there was a question about duration, if I got it right. From trial evidence, we know that using, whether it is Zomita or denosumab, we tend to use them upfront from the time of diagnosis of myeloma for at least 2 years from there on. Beyond that, it's not very clear whether we should continue to use it indefinitely or stop at some point. Most people would stop at some point after that, and then when the relapse happens, we tend to restart them. It's not wrong to continue to use it, but maybe in a less frequent schedule, maybe once every 3 months or so. And that is usually widely accepted by experts.
Okay, I'm very glad that we have a number of questions coming through. I'll just, one of them is quite interesting with a new... is this question of allogeneic transplant versus CAR-T treatment? Okay, so the question was, what are the pros and cons? Which one is better in your opinion? And what are the risks? And I think this would be interesting to hear from the panel because it's, somewhat controversial. I would only say that allogeneic transplant is a much more established treatment. People have been doing allogeneic transplant for years. And in fact, the outcomes are getting better and better because of better ability to control the treatment-related problems. So the survival and outcome of patients undergoing allogeneic transplant is much better now. And also we know because of the fact that allogeneic transplant has been done for so many years that truly patients can be cured by allogeneic transplants because we have patients who survive 20, 30, 40 years when they do that. But allogeneic transplant is traditionally only available to much younger patients, patients usually below 50 years of age. So it's not something that every patient can undergo. So that's for allo. CAR-T is very promising because of the high response rate and so on, but it is not without serious toxicity. So when you say which one is more, have more complications and so on, I would say that actually the nature of the complications are quite different. The CAR-T complications, a lot of them are acute, short-term, dangerous, but you have these long-term effect that requires maintenance treatment. Similarly, for allo transplant, you have early graft-versus-host disease, late graft-versus-host. So there are short and long-term problems that the nature is a bit different. So they both have these short and long-term problems. So they're probably about the same there. The problem with CAR-T is that we don't know what's the long-term outcome, and it's the accessibility. Like today, you want to do an allo transplant in Singapore, we can do it. But if you want a CAR-T treatment for myeloma, I would say we don't have one, right? So that is the main issue. In 2-3 years' time, when you have CAR-T approved or trials available in Singapore, now these questions then become a bit more challenging, and I suspect people will be veering towards trying the CAR-T first before doing the allo transplant. I mean, that's my personal thought, but I would like to hear the rest of the panel.
I think most of the points that Professor makes are absolutely spot on. The thing to mention is most trials that have involved CAR-T, the patients did not go through an allogeneic transplant beforehand. And second, it is even with the CAR-T, it's not one treatment, right? As Prof. Chung's session was he was mentioning in his session, there are CAR-Ts where you can harvest most of the time your own T cells and then re-engineer them before infusion. But there are now increasingly CAR-T treatments using other donor T cells as well. So it's going to be an evolving landscape of treatment. I think there is going to be quite a while before we get a clear answer towards which one is better. And they have different spectrum of side effects, right from the word preparation, everything is quite different.
So just to add, so what my colleagues have mentioned, definitely I agree. But the context of when we want to consider CAR-T, when we want to consider allogeneic transplant, sometimes could be very different for a very, very young patient who may potentially wants to be have a chance to get to be cured of multiple myeloma, and he has got bad myeloma genes. Then allogeneic transplant is something that I would consider. On the other hand, we also ought to look at the reimbursement. So right now in Singapore, if you're a Singaporean, allogeneic transplant is very heavily subsidized by the government. But if you're talking about CAR-T, we have absolutely no idea how much it's going to cost. But right now, as a ballpark in America, if you go for CAR-T, just the product of the CAR-T alone, minus the hospital stay and so on, you're looking at about $400,000. When it comes to Singapore, I do not know what the price is going to be. So finances is also another major consideration before we decide what is best for the patient. But things are still evolving, and of course, we'll be more than happy to just to keep abreast with the latest in the literature, so that when the time comes and when you need to make the decision, then we all the doctors will give you a very unbiased opinion on what is best for the individual patient.
There's another question about stem cell transplant, because it was mentioned that nobody mentioned anything about stem cell transplant. Doesn't mean that it's not needed now. And the question is, what's the difference between that and the CAR-T? I think there are many things that we didn't mention today because they are standard already. I mean, nobody say much about Velcade and so on. So these are standard treatment that all myeloma patients will go through, including the stem cell transplant. It is definitely still beneficial, and like I said, the CAR-T is something that is not available now. It's something for the future. Now, certainly in the future, it is quite possible that if the CAR-T is mature enough and really safe enough and effective enough, that we may not need to do an autologous stem cell transplant. That's quite possible, but not by today's standard. Today, the autologous stem cell transplant in Singapore is relatively cheap, is very safe, is very effective, it's heavily subsidized, as Daryl have said. So cost effectiveness is really very outstanding. So I think we'll do that. The CAR-T treatment is, in terms of procedure of what we do to the patient, is about the same in principle, but actually behind the scenes, the science and the thing is actually completely different. The principle or the concept of treatment is actually quite different. The autologous stem cell transplant is using the chemotherapy to treat the cancer, which is the high-dose melphalan. The stem cells are to rescue and allow the body to recover. Whereas the CAR-T is completely different. They are using the immune cells to attack the cancer. So CAR-T in principle is closer to allogeneic transplant because the allogeneic transplant principle is the same. They're using someone's donated immune cells to attack the cancer. So the allogeneic transplant is actually the original old version of CAR-T, if you want to think about it in that way. So they're quite different actually, but today stem cell transplant is still, autologous stem cell transplant is still one of the key standard treatment that we have. Any other comments?
Nothing much really. Just wanted to reiterate that, yes, absolutely, transplant is useful in the upfront treatment of myeloma. Sometimes if we've been lucky with a patient that one transplant gave them a fairly long period of remission, either with maintenance or without, and if the patient is still fit second time round, well beyond 3, 4, 5 years, if they have managed to remain very well with myeloma, we do consider a second transplant as well if they are fit at that point. So, and in our context in Southeast Asia, really, if you think about the kind of treatments that are available, stem cell transplant may not sound that cheap, but it's actually one of the cheapest ones that we have. So I think from both what Daryl, Dr. Tan was mentioning about the cost of treatment, it's relatively cheap and safe. Not that we have been doing it for years and years and years, and do consider transplant as a very important part of the treatment for myeloma.
I'm from Tan Tock Seng. We do not do transplant in Tan Tock Seng, but we refer our patients who need transplant either to NUH or to SGH. But I do notice between the two hospitals, the criteria for transplant sometimes may be a bit different, in particular for patient who has got renal impairment. And you see the patient who has got renal impairment, the toxicity of the procedure is higher. And so there's even within this, there are two different views between the two hospitals. That's my observation.
Just move on to some other question. There's one relatively simple one that I'll just answer first. So someone asked about the average time for remission of myeloma. In myeloma, as you know, the patients usually have the disease, get treatment, get better, so in remission, and then relapse again, treat, remission again. So there are actually multiple times of remission, but very often the remission is the longest the first time, and then it usually get a bit shorter and a bit shorter and a bit shorter subsequently. On average, the first remission, using our data and international data, is usually about 3 years, but with newer drugs introduced to the beginning, this time may keep changing in the future. But it's very variable. This is average time, which also goes to show that some patients may relapse very early. We certainly have seen patients relapse after 2-3 months of the transplant, within the first year, but we also have patients that kind of relapse after 7-8 years, or some actually never relapse, right? So it's a big range, and the usual advice to the patient is to just continue to follow the instructions of the doctor, go back for regular checkup so that we can pick things up early. and don't obsess about numbers like, this, because it's really different for a different patient. And you will not know for yourself what it is until they actually happen, right? I mean, so it's, these are the general pattern. Mauli and Daryl, want to add anything to that? No? Okay. The next question is on maintenance therapy. This one is, as usual, quite controversial. So the questioner was asking panel's views on maintenance drugs in terms of efficacy and financial burden. Maybe Daryl, since you're a financial person.
So let's say, for instance, a patient who has come off transplant, and usually we will discuss about maintenance. So this discussion actually I take into account many factors, because your reimbursement, because right now there are a few ways we can do maintenance. One, the standard or what is recommended is with Revlimid. But the cost of Revlimid, if you apply it in an indefinite duration, the recommendation right now is that if you're on maintenance, you do it indefinitely, because you are as good as you are on the drug. Right? So this is what the latest studies have shown. With Revlimid, the cost is the issue. So if a patient is well insured with integrated shield plan, yes, that is ideal anyway. That is that's recommended in all international guidelines. However, if a patient has got financial difficulty with Revlimid, then the next consideration is a drug called thalidomide. But unfortunately, thalidomide is the first generation lenalidomide. It comes with this side effect called peripheral neuropathy. Sometimes it can be very troubling for the patient because of numbness and tingling sensation on the feet, and sometimes it could be permanent. So as far as possible, if financially it's feasible, I do lenalidomide first. If not, then thalidomide. But thalidomide usually you can never do indefinitely, because many patients will have side effects. And on the other hand, I also look at the genetics of the disease. If a patient has got bad genetics, like 414 translocation or deletion 17p, so these are bad genes, it has also been shown that with lenalidomide alone, it may not work. So these are the patients where I may consider doing bortezomib or Velcade as maintenance. When we're talking about maintenance, we're talking about taking a drug like it is your anti-cholesterol medication long-term. So long-term, the side effect is always a consideration. Again, with bortezomib, long-term side effect is still nerve injuries. Now there's a new drug called ixazomib that has been tested. It's like an oral form of Velcade, but you take the pill once a week as a maintenance. So for patients who already have got numbness or nerve injury, ixazomib is a drug that could be considered, but then again, this is another very expensive drug. So overall, I don't think there is a standard answer to how anyone does maintenance. I look at several things: patient factor, patient's reimbursement, and patient's genetics, and the risk of the myeloma before putting forth a recommendation for the patient.
Anything to add, Mark? Nope.
I completely agree. Sometimes with the management of myeloma, it is almost nearly like solving a Sudoku puzzle. So you just put the different pieces, the patient, the genes, the myeloma presentation, the patient's toxicities that they've had from treatment, from the disease, and then you put everything together, then you get a neat puzzle that we know how we solve this best. So I think there's no one consideration for every patient. It's just completely individual dependent. I don't have anything to specifically add.
So on the other hand, I have got some patients coming from Indonesia. And they actually already sold their house to go for a stem cell transplant. So these are the patients. Sometimes I would say, maybe instead of selling another house to pay for maintenance, perhaps you could consider conserving your resources for the treatment of the next relapse and don't do maintenance. So that is also a possibility, just for patients who are, especially patients who are self-paying and getting a little bit tight financially.
So while the mind is with Mauli, maybe I'll ask him a question. There's this question that was asked. It's not quite complete. I hope I get the question correct. I suspect this is in relation to the new drug that was probably your media release on carfilzomib, I suspect, because it's directed to you and there's a new thing. I think so. I'm not sure who asked that question. Is this correct? You're interested to know about the new drug that was mentioned in the newspaper for myeloma?
Yeah, it's me.
Yeah, oh yeah, that's the one, right? Yeah.
It's from Germany.
Yeah.
The trial that was mentioned actually was new at the time of launching. The drug was new at the time of launching. It's not new anymore. Many of you might have known about the drug called carfilzomib, which is now in Singapore, been around for about 5 to 6 years now. So that was the one that was, it was mentioned. Was there a specific question about the drug?
No, what is the outcome and progress for myeloma? So maybe
Okay.
a bit about the result.
Okay. So that particular trial involved, so now we talked briefly about the phases of treatment for myeloma. So the first phase, as soon as patients get diagnosed, is what we call as induction treatment. And for some time now, we know that when we use a combination of 3 drugs, patients do better, the outcomes are better than compared to using just 2 drugs. And so that phase of induction, we use 3 combinations. Usually Velcade was one of the drugs, either cyclophosphamide or thalidomide being the second drug, and dexamethasone being the third drug. So in this particular trial, we replaced the Velcade with carfilzomib. So we use carfilzomib, cyclophosphamide, and dexamethasone as an induction treatment. This was a trial that was specifically used for patients who were eligible to have a transplant. So after a certain number of cycles of these 3 drugs, patients went through harvesting of their stem cells, and then they went on to have a transplant. After they finished the transplant, they received 2 more cycles of the same 3-drug combination of treatment. This phase of disease treatment is what we call as consolidation treatment. Then we go on to the maintenance that we were all talking about. But before they went on to a maintenance phase, patients had a bone marrow assessment done, and they had something called the minimal residual disease assessment, which Dr. Darrell Tan was talking about earlier. So in patients who had still detectable amount of disease, but in a very, very small quantity, that is what we call as MRD, patients went on to have this maintenance treatment with the same drug called carfilzomib, which was all, obviously this is not part of a clinical trial, and hence the medicine was completely free for patients. And then subsequently, we continued to assess the patient, and we now have reached a stage that we were able to look at analysis and see how the patients have done. The other important thing about this particular trial was this was for what we call as high-risk myeloma patients alone, which means that patients who had these very expected to do poorly with really bad kind of myeloma genes within them were the patients whom we recruited into this trial between SGH and NUH. So we look at and compare. So this was, within the context of Singapore, we know the population is going to be small. So we didn't have any comparative arm for what we use this. For example, we could have compared saying, okay, we are using carfilzomib with this. Why didn't we compare it to Velcade? But if we have to do that, it will be much, much more cost-wise for running these trials. But also, how do we assess? So then we have to compare it as such, as a single-arm trial where how much have these patients responded. So we had very good response. Nearly 60 to 70% of patients reached what we call as a complete remission, which we know is good, but not the best. But we do know that nearly 25 to 30% of patients reached a stage where not only were they in CR, but they actually reached a stage where even when we use special techniques like MRD, we couldn't find evidence of disease. So it's still an ongoing process. We're still collecting data so that we see, how on a longer term, beyond 3, 4, 5 years, the patients who are particularly become minimal residual disease negative state, how do they do? Because it's important that in these high-risk patients, how they perform when they get to that stage. It's important for us to find out how it goes for them.
Yeah, maybe I would just add and make some generalization that, although we have improved a lot in myeloma treatment, there's still some small group of patients which have, bad disease, what we say high-risk disease. And that is the group that we still need to work very hard to tackle, to improve and make them as good as the rest, right? And the generalization is that all these new drugs that we're now using to treat relapsed disease like daratumumab, carfilzomib, if they are good in relapsed disease, they are probably better earlier on in newly diagnosed. So as we move these treatment earlier and earlier on, there is a cost issue for sure, but actually the outcome of the patients will probably continue to improve, which is why CAR-T now we saw treating patients with 3 or 4 previous relapse. I would say that if it's a successful treatment in the future, it could be CAR-T right up front, and it will potentially change the landscape of these patients, because if you don't relapse, you're cured at the beginning, then all the costs that we're talking about may be more compelling to even pay more upfront if you're cured, right? Rather than keep paying, over the years. So I think this is the trend that things are moving, and in the coming years, you'll hear more and more of these things. I want to touch on this one, which I think is also important. There's someone who asked a question about dexamethasone, right? Patients are surviving way longer now. There's many rounds of treatment. Every round you get dexamethasone. You seem to be on dexamethasone all your life. And there's a lot of side effects. The cataracts start to come, the infections start to come, your legs are swollen, you're getting, diabetic, and so on. The question is dexamethasone necessary in all the cocktails? And what if you don't use it? What would be the downside? And maybe linking, everyone can answer this question.
I do notice patients who've been on dexamethasone, they develop cataract as well as fracture of the hip due to osteoporosis. My practice now is, I try to cut back on this when I see patient has a lot of bone disease to begin with. For instance, if my patient's on lenalidomide maintenance, I will withdraw the dexamethasone weekly after some months. If the patients manage to keep the disease in check, I will stop the dexamethasone part.
I think I would completely agree. I do fairly same thing. When patients, it depends on patient's response, right? Induction treatment at least is finite. You get 4, 5, 6 cycles of treatment, and hence the dexamethasone also stops at the time of induction treatment ending. But it's usually the maintenance part that is particularly a problem. So you start off with lenalidomide and dexamethasone, and then there's no stop date to it, unfortunately. However, if you're cognizant about how the patient is responding, if the patient has already reached a stage of very good remission or even a complete remission, is there a point really of continuing the dexamethasone? Probably not. Probably not a strong case in any way. So we do think about that, those patients. And secondly, I go back to the same issue. It's not a one-size-fits-all approach. It has to be based on the patient's response, and especially with regards to the toxicities. We use the same dose of dexamethasone with the same combination of drugs. One patient has absolutely no issues whatsoever, but the next patient, is absolutely wrecked because of dexamethasone. They have, cataracts. They become diabetic. They weren't diabetic before they started. So we have to teeter it to how the patient's tolerability to that particular drug is, not just for dexamethasone, but for everything else as well.
So if part of your question is whether we have evolved to such an extent where we can drop dexamethasone, unfortunately, the answer is still no. We celebrated when we could do without conventional chemo upfront. For the longest time, we were using this chemo called VAD. It's like leukemia chemo where a patient stays in hospital, you need an infusion upfront. So when we stopped that totally, we were quite elated. But dexamethasone, unfortunately, it is still essential, especially in the beginning, because it's an anti-inflammatory drug. So in the beginning, when patients come to with myeloma, there's some inflammation here, we need to quickly arrest certain things like high calcium. So dexamethasone in the early phase of myeloma treatment is essential, but later on, depending on the side effects, we will want to tail it off. And sometimes dexamethasone is actually a very good drug in combination with other drugs. If you're let's say if you're on ixazomib, you can sometimes get very bad nausea, diarrhea. The dexamethasone is the one that's actually suppressing all these side effects of some of these drugs. Yes, we are still evolving. Right now, the dose of dexamethasone, we've found that we don't need high dose, it's cutting down. But then again, right now at this point, especially in the front line, or when we combine with chemo, other new chemos, it is still an essential drug, but we are all mindful that there are toxicities, and monitoring for side effects is always at the top of our priority.
Yeah, so I would just add that, what my colleagues say are all true, but we also have seen that over the years, as Darryl has said, we've gone from chemo to no chemo. In fact, in the past, we used to give a lot more steroids, 4 times more steroids for treatment. And there was a study that shows that, in fact, the way that we give it out, which is once a week, is as good and, in fact, safer, less side effects than the higher doses of steroids. So I'm also not, I don't think it's beyond possibilities that in the future we can give less steroids. Whether we can do without steroids or not is a completely different question. And I think within the context of the Asian Myeloma Network, we're quite keen to look at some of these studies that are not very sexy new drugs type study, but may have real impact on patients' outcomes. So one of the studies that we are thinking of is actually to look at comparing a 40 milligrams per week with maybe a 20 milligrams per week dexamethasone with the rest the same. And there is no rhyme or reason why 40 milligrams is, it's not based on any very good scientific rationale and so on. So, why not 20? And I think these are some questions that we can ask. And I think if we can see that it doesn't impact on the response, but may benefit the patients, then we can, slowly see whether we can get away with less and less steroids that will help our patients. So I don't know about time. Are we? 哇，还有的。几点? When's the finishing? Just keep going for the whole day, is it? Okay. I mean. I would, let me see, I went on. Okay, let's do this. So there's one question on, this questioner asks, I've heard about whole body hyperthermia combined with chemotherapy in moderate doses to treat myeloma. What's your opinion? My opinion is I've not heard of this, so it cannot be standard of care. There are many, if you go onto the web and you read all the blogs and so on, people have tried different things. We also know that there are a lot of, I don't know, whether they are practitioners or not really qualified licensed practitioners, but the people doing all sorts of funny things out there, just like using stem cell therapy to make you look younger and all those. Those are non-approved treatment, right? Whether they work or not is another thing. But all I can say that is not approved. It may work. I'm not saying that it will not work, but it's just that it hasn't been robustly studied and certainly not treatment that we will recommend you to try, because there are other much more established, much more effective, much more well established treatment that we can give. And I think, this is one example. There could be another 20, 100, 200 examples of funny treatment that people may have said that it will work, because whatever you read on the web would be things that have worked. Nobody will tell you things that have not worked, particularly if that blog is from someone that is an advocate of that thing, right? So I just caution, always check in with your doctor before going to try these things. Any other kind of advice from our panelists? No, haven't heard of this? Daryl? No? Linking? No, yeah. So absolutely haven't heard before. The next one on diet during remission. Okay, when someone has finished the treatment and is well and so remission, any special dietary recommendation? Just first disclaimer is there's no dietitian here. But anyway, does anyone want to give some thoughts on this?
I guess it again depends on what stage of remission you're on, whether you're on maintenance treatment or not. If you're on good going amounts of lenalidomide, you might still have periods where your neutrophil counts are going to be low, and hence you still need to watch what you eat. Second, it also has to do with, what have you been left with in terms of complications from before. For example, some patients post-transplant can still be left, even when you're on no treatment subsequently, you can still be left with some kind of borderline blood count. So I think the bottom line rule that I tell my patients is healthy, hygienic, properly cooked diet. Unfortunately, no dodgy takeaways and no kopitiam for most of the patients, especially around the the transplant and the peri-transplant period. Other than that, I think there are lots of concerns about supplements and things. And I think it was not last year, the year before.
Yeah, there was 1 year
when we had a dietitian. I think it's maybe a gentle reminder for us to probably think about the next session to include a dietitian again, maybe.
So I get this a lot. There's always a myth that you've got cancer, you should starve your body of glucose and sugar. So no, we do not believe in this. In fact, I have one patient, an elderly lady with myeloma, so I gave her a very simple treatment, and 1 month later after diagnosis, she lost so much weight and she was so scrawny that she was going to collapse. She looked like she was going to collapse any time. When I found out it was actually his son who refused to let this lady eat, thinking that starch, sugar will feed the cancer cells. So actually that was detrimental to her health. So to be honest, I mean, myeloma is not just the drugs that are killing the cancer cells. Your own immunity is also fighting the myeloma. So do not starve your immunity. Even if the concept of no sugar is correct, you're starving your immunity. Your immunity is needed to fight myeloma as well. So have a normal diet. Do not deplete yourself of sugary or starchy food, because that myth of starving your cancer to death is probably unfounded.
Yes, I was just about to say the same thing. In fact, we need good nutrition for our good immune system, our strong body. And if we were to undergo chemotherapy, we need a strong body to be able to withstand all this chemo. It's very tough for anybody to receive chemo. These are all cytotoxic medicines. Every round of treatment, we are weakened by this. So are we going to get ourselves even more weak by starving ourselves? Of course not. We need to be ourselves strong, get good nutrition. Do not believe in the old Chinese supposed way of selecting certain food and cut off certain foods. That's my comment. Of course, nutrition supplement-wise, we always prescribe calcium and vitamin D. Yeah, but be careful, because we check the blood calcium level quite often. If the blood calcium level is too high, then of course you need to be stopped for a while. That's my comment.
And just also be cognizant of the fact that many people are going to have different other things associated with myeloma or even unrelated to myeloma. You might be diabetics where the diet is going to be different. You might have kidney problems where you might have been told to avoid specific foods that are rich in potassium and so on. So really, if you are in doubt, ask your doctor to refer yourself to a dietitian and take what is the right thing that is suited for you.
Yeah. So this all the advice here is absolutely correct. Very often, this question is asked, anything I cannot eat? Then usually, no lah, eat everything lah. Then the guy look at me, is like, what? So I can tell you that in the population, the public, right, it's this conception that if I'm sick, particularly because Chinese is very strong in this, cannot eat certain things, like chicken cannot eat lah, seafood cannot eat lah, very poisonous lah, and all these things. It's actually not necessary. There's no real solid basis to this, is all I'm saying. So there's another thing about food here, not quite exactly, it's about Japanese seaweed. Would this interfere with treatment or help with treatment? And again, I will let the others answer as well, is that I don't know, right? Because again, these are not really scientifically studied and so on. So I really don't know whether it will help or not. I mean, a lot of patients do come and ask, can I take some herbal thing here and there, with the treatment? My usual advice is that when you are taking your active treatment, like your Velcade and so on, better not take to interfere. But when you're in remission and you're not taking any treatment, if you want to try some of these herbal things or whatever, it's okay to try, as long as ask your doctor, make sure it's not something that may be dangerous or controversial. If there's no harm, you can actually take, and then, if it helps, it helps. It doesn't, then, it doesn't cause any harm, right? So it's a practical approach. But I don't know, I'm not familiar with the literature. Do you all know anything about seaweed?
I didn't imagine seaweed around the different parts of the world would be very different. So I thought Japanese seaweed is probably the same as rest of the seaweeds, but apparently not. Yeah, I don't know.
So, Darryl, any knowledge on this? No.
Not Japanese seaweed, but Japanese green tea. I mean, there's some interference with the absorption of Velcade. So usually when you're on Velcade, I ask patients to avoid green tea, not seaweed.
Yeah. So we don't know about seaweed as such. Linking also don't know. Yeah. Any other question? Yes. Baldev.
Thanks for the fantastic talks. No Indian today, a lot of Indians believe in turmeric as a very good supplement for anti-inflammatory. Turmeric, any evidence of benefits of turmeric?
Interestingly enough,
Is curcumin from turmeric?
yes, correct.
Yeah, so
that's the
curcumin,
compound.
Some of the people are curcumin.
Well, it's a very, very good and very relevant question. One of the foremost investigators in the world for myeloma is Dr. Vincent Rajkumar. As the name might give it away, he's actually an Indian born in South India, but there's a lot of curcumin and turmeric being used. And I believe he's studying the effect of myeloma, effect of turmeric on myeloma, but I don't think the results have come to being kind of used as a treatment on its own, but it's going to be something that's going to be used with other treatments. And the short answer to that is the results are not known yet, but when they used it in a Petri dish on myeloma cells, there's quite a robust evidence to say that the myeloma cells are being killed by the compound. So if it is going to be part of your diet anyway, I don't see why you shouldn't continue. But if you are talking about specific dosages in terms of tablets and stuff, I don't think there's any guidance to say how much you should take or so on. But there is definitely a clinical trial on curcumin in myeloma.
Yes, sir. Yes.
Fucoidin. And they say that some Japanese doctors have studied and say that it's effective. But when you say what I'm doing now for myself is that I take it, but outside 1 day before and 1 day after the Velcade treatment, I don't take it. Is that good enough? Or I should avoid altogether?
Oh, so no. The question is related to the Japanese seaweed, and the gentleman is saying that I don't know whether he read online or somewhere that the seaweed may help. So he's taking it, but he's asking that if it sounds like he's on Velcade treatment as well.
Yeah.
So if he's taking the seaweed but stopping the seaweed 1 day before the Velcade, and then also don't take 1 day after the Velcade, but take on other days, is that okay? I guess a lot of these things is that, so first of all, truly we don't know whether it will help or not. Is number one, that's the one first issue. The second issue is that does it interact with the active drugs that we're giving you, which is Velcade? So the example of green tea, we know that it interacts, so you shouldn't drink green tea or take high vitamin C containing elements, because that's another thing that has been shown to interact with Velcade. So if you say that I stop 1 day earlier and then 1 day later, then the question is, we don't know how long the seaweed stay in your body, right? So if the seaweed stay in your body for 2 days or 3 days, then it will interfere even if you stop. So there is a lot of these questions that we cannot answer just because nobody has studied how long because after you eat the seaweed, it gets digested, there may be some chemical compounds that then get absorbed in the body. So we don't know how long these stays, and it may interfere with the drug absorption and so on. So these are the kind of questions that I guess we don't feel qualified to answer just because we don't know, and nobody has studied the seaweed in that kind of detail. So the usual advice, like I said, I will give my patient is don't take herbal medicine or seaweed when you're taking the active drug. Particularly if the drug is working well, just carry on with it. But you can take these other things after you finish your treatment. Because some people say, I want to I want to adjust my thing. After that, make me feel better, adjust my well-being. Then you can take these things after the active treatment is finished. Because while things is working well, it's fine. But some people may come back with some odd side effects. Then we have to wonder, is this due to the drug that we're giving you? Is this due to the seaweed? Is this due to the interaction with the seaweed? Then we are in a bind, what to adjust, right? What to adjust. Because we know that side effects may happen. But a lot of patients come in with sometimes unusual side effects. Then upon asking, you realize that they're taking all these other things out there. Then really, maybe stop all those things first, then continue the drug. If it's still there, then maybe do it. Then we have to play a lot of detective work, which may make it very difficult to manage. I mean, that's the advice. I'm sure the advice will be similar.
I think so. May not be directly related to the seaweed, but there are many marine organisms and plants that have got very robust anti-cancer activities. So we don't. I guess we don't really know. There is one recent myeloma drug that we came to know about called plitidepsin, and it's actually derived from one of the marine compounds, and it seems to have even more robust activity similar to Velcade in controlling myeloma cells. So what we don't know, I guess, is it's not just simply dismissing things we don't know. It's just that we truly don't know whether it is going to add on to the side effects of Velcade. If you have, I mean, it can be completely naive looking as a seaweed, but if it really has a compound that can either interact with or might very well be very helpful in controlling myeloma, but in that process, if it has a similar mechanism of action, they can actually add on to the side effects of the same drug that you're going to be on. So I guess unless we are, in this day and age, unless it is specifically studied, we unfortunately cannot give out a recommendation.
But can we treat it like we take any other normal food? Because if we take other normal food, we also we take a lot of other foods, which we are not quite sure whether they have any other compound.
Yeah, so if the seaweed is in the, I don't know what this seaweed is. If it's in the normal context of the seaweed we take with some of our food, then it's fine. But if it's a pill or a concentrate or a different kind of thing that is derived from the seaweed, then I would say caution, because the dosing may be quite different. It may be many times higher than what you will eat from a seaweed that you put maybe when you go to a Japanese restaurant and they put some seaweed in soup. Yeah, so be careful. Although it's from the same thing, but sometimes the concentration does matter as well.
Understand.
Yeah. So same thing as what Maoli have said about turmeric and so on, right? If it's the usual in the diet, but if you buy a pill, a turmeric pill, curcumin, the dosing may be quite different, and that it's not controlled, then we don't know.
So if I take at a normal, like the Japanese people, they actually take this seaweed. So if I take at the same level as what they are taking per day, is probably in the normal diet. Is it probably okay? Because actually, the first few weeks I do feel a bit uncomfort in my body, but when I take this Fucodan, it seems to help. I take it normally on the third day after my treatment. So I take it on Thursday, I have my Velcade. Friday, I don't take. I take it only on Saturday, then I start to take one pill, which is, they say, is equivalent to the normal diet for the Japanese who is taking this seaweed.
So again, the rest can chime in, but the advice here is that if it's working well, I mean, you're feeling well, there's no side effects, and when you go back to your doctor, they check your response is also going well, then there's no harm. But just be mindful that there may be harm. It's not always just benefit, right? So there may be harm. If you experience some unusual side effects, or your doctor is saying that, hey, your response is not as I would expect based on the other patients that I treat with myeloma on the same drug, then you are in a way taking an educated risk, then you must stop the seaweed or something after that. But if everything is going well, again, I think it's a practical approach. There's no, it should be fine.
Okay, thank you very much.
If you feel well, okay, the monitoring seems to respond well. In your case, if you feel well taking it and the treatment progress well, that's probably okay. But it may not apply to the rest of the patients. The rest of the patients, if they want to try, they got to be very cautious. Yeah, that's all I want to say.
Okay. Any other? That's it. I've been given the thumbs up that's it. Thank you very much to the panelists for the very active discussion. Thanks for all your questions. Thank you.